Today I will discuss the one important thing that is the pulmonary embolism, and it is most time in our hospital it is most of cases it is undiagnosed. So in which cases we will suspect the pulmonary embolism? Let's see. First of all আমরা suspect কাদের করব? Pulmonary embolism. Pulmonary embolism. কাদের আমরা সাসপেক্ট করব? সিমটমস কি কি সিমটম নিয়ে প্রথম পালমারি এম্বোলিজম আসবে? First symptom, that is the most common, dyspnea. That is should be unexplained dyspnea. So first of all we should exclude the common cause of dyspnea, CVS and respiratory common cause of dyspnea we should exclude it. After exclusion we will suspect the unexplained dyspnea. Then second is the chest pain. It is a typical of pleuritic chest pain. It is not in a actually it are not normal case of chest pain that is seen in ACS, acute coronary syndrome, or any pleuritic chest pain. It is a atypical chest pain, and that is the mainly pleuritic. Why pleuritic? Because in lung we will see when this embolus obstruct the small vessels and the severe infarction happen in the small tissue of the periphery of the lung, and this causes pleuritic chest pain. These are the most common two symptoms. Let's see signs. Most common signs we will see increase heart rate, that is a tachycardia and tachypnea. Then we will see the clinical features of the right ventricular failure. We may see the right ventricular failure. What are the signs? JAP may be increased. We may see the S3 gallop, or we may see the left parasternal hip. So by seeing this, we can diagnose the patient has a right ventricular failure, and we suspect the patient may have pulmonary embolism. Then next step, do oximetry. SpO2 should be low. Then in our clinical practice, next instrument we have ECG. Most of cases ECG is normal. Findings, if abnormal findings are non-specific, there are some non-specific non-specific signs include strain pattern. Strain pattern is the most common, but these are non-specific. Others finding sinus tachycardia, ST and T wave abnormality. These are all of non-specific signs. Specific signs. What are the specific signs? Specific signs include lead on within the lead on S1 wave, lead 3 we will see Q wave, and lead 3 we will show the T wave inversion. S1, Q3 and T3 pattern. These are the specific, but it is not seen in most of cases. But we may see new or BBB pattern if patient has a previous ECG pattern. And if in non-specific we see this T wave inversion usually seen pre-codally V1, V2, V3 and V4 leads. We will see the T wave inversion. So after this we'll discuss about the symptoms, signs and ECG, spirometry. Then we have chest X-ray. It is non-specific and most of case it is normal. Find if findings if present, findings include suppose there is a lung. Within this lung there is central oligemia due to obstruction main bronchus, main artery obstructionের জন্য এই সেন্ট্রাল এরিয়াতে আমরা অলিগেমিয়া পাবো। যদি আমরা পেরিফেরিতে পাই এই সাইনটাকে বলা ওয়েস্টার মার্ক সাইন। ওয়েস্টার মার্ক সাইন যদি আমি সাপোজ এলিভেটেড ডায়াফ্রাম অ্যান্ড পেরিফেরিতে পাই, লোয়ার পার পেরিফেরি, that is called hump, that is called hampton hump is seen in when small vessels involved, small vessel involved, and it also indicate that is lung tissue is infarct. These two are the common finding we will see. One is the Westermann sign and the second one is the Hampton hump. Let's see next step. Next step we have echo. Next step we have echo, and in most of cases echo we, by doing echo we will see that is a right ventricular dysfunction. So if patient has sign, symptom, ECG, SpO2 and echo suggestive of right ventricular abnormality, we should think about pulmonary embolism and it is acute condition. When you suspect, next step we suspect till now pulmonary embolism, then we'll follow on a score, that is the Wells score. If the score is less than 4, then it is less probable. If it is greater than 4, 4 or less than 4, if it is greater than 4, high chance. Let's see Wells scores. Total 7 score. First score, patient sign and symptom suggestive of pulmonary embolism. Number is 3. Second is other cause of dyspnea and chest pain excluded. That is the 3 point. Third number, if patient has heart rate greater than 100, that is point is 1.5. If patient have history of surgery or immobilization, then it is 1.5. If patient have previous history or DVT or any pulmonary embolism, that is also 1.5 point. Last 2 point, if patient has hemoptysis, then 1 point. If patient have cancer and that is treated for at least 6 months, that is a 1 point. So one important thing, this 3 point only 2, 1.5 value it is 3, and last 2 point in only 2. So by this score, if the score is less than or 4, it is less probable. If score is greater than 4, it is high probable. Let's discuss other cause. What are the other cause that is simulate this pulmonary embolism? So DD include for chest pain, that is the pleurisy, costochondritis. Costochondritis has local tenderness. Pleurisy has inspirational pain. Acute coronary syndrome, patient may have bronchitis, pneumonia. For shortness of breath, congestive heart failure, aortic dissection. Aortic dissection patient has also chest pain. Aortic dissection, idiopathic hypertension, the pulmonary hypertension. These things, these differential diagnosis chest pain, shortness of breath, we should exclude. Then next step. Here forest step key. Next step key. Patient has less than 4 score and patient has more than 4 score. If the patient has less than 4 score, we do the D dimer. If D dimer normal or high, if normal, we exclude patient has no pulmonary embolism. Ah! If patient is high, do CT scan. If greater than 4, do CT scan. If it is normal, then exclude pulmonary embolism. If abnormal, positive, then we will diagnose a pulmonary embolism. Same as CT scan. So after this, we will diagnose, confirm the case. It is a case of pulmonary embolism. Next step, what we will do? Next step. Next step, we will evaluate patient risk stratification. That is, will stratify the patient according to mild, moderate, or severe. So this risk stratification will do by anatomical extension of embolus, or on that is follow PESIS course. Anatomical variation clinically or by doing the PESIS score. Let's see the anatomical or clinical. Let's discuss the anatomical or uh, clinical evaluation of risk stratification. So according to anatomical the risk stratification, there we have three cases. One is the massive patient may have massive pulmonary embolism. It is only in 5 to 10%. Second is submassive, and the hello. So anatomical stratification, we have three category. That is a massive pulmonary embolism, submassive pulmonary embolism. That is, we will see in 20 to 25% cases, and third one, small to moderate pulmonary embolism. That is a 70%. What criteria? What are criteria that will satisfy this massive pulmonary embolism? First, we'll see in these cases patient is hemodynamically unstable. In these two cases, patient is stable hemodynamically. But in these cases, patient had right ventricular abnormality. The right ventricular abnormality that include enlargement or any dysfunction clinically. By echo will diagnose the enlargement or any dysfunction or any increased cardiac marker যদি বাড়ে, পেশেন্টে যদি ডিসফাংশন থাকে, পেশেন্টে যদি ইকো অ্যানোমালি থাকে, তাহলে উইল classify this case with even patient have the hemodynamic stable, then we will classify patient have the submassive pulmonary embolism. In that, what are the cardio biomarker? These include the BNP, CKMB. These are the cardiac biomarker. In small cases, patient is stable, patient has no abnormality uh, of right side of heart. And in case of massive pulmonary embolism, patient is hemodynamically unstable, and obviously patient will have uh, uh, right heart, right ventricular problem, and patient may develop thrombus in this case, massive case, the major thrombus in right ventricle due to the clogging of the blood. So after risk stratification, risk detection by PESIS score, this is the huge score. Will follow so many points, and it is to the it is usually now it is ideally followed by, but clinically we will do the anatomical classification. So after risk stratification, we have two options: patient has low risk and patient is high risk. For low risk, we do only anticoagulation using is sufficient. অ্যান্টিবায়োটিক দিলে হয়ে যাবে। হাই রিস্কের ক্ষেত্রে যেহেতু পেশেন্ট হিমোডাইনামিক আনস্টেবল, ফার্স্ট উইল স্টেবিলাইজ দ্য পেশেন্ট বোস্ট হিমোডাইনামিকলি প্লাস হচ্ছে রেসপিরেটরি সাপোর্ট, ভেন্টিলেশন, আইসিইউতে পেশেন্টকে পাঠাতে হবে। 2 নম্বর হচ্ছে পেশেন্টকে এখানে সিস্টেমিক থ্রম্বোলাইসিস করতে হবে। হোয়াট ইজ সিস্টেমিক থ্রম্বোলাইসিস? সিস্টেমিক থ্রম্বোলাইসিস means through a vein we will introduce a catheter, and through this catheter we will give the anticoagulant for thrombolysis. Usually femoral vein, subclavian vein, these veins are chosen. Then we may follow the IVC filter, may use the IVC filter or surgical embolectomy. By this doing we may overcome the high risk cases, in which cases massive pulmonary embolism is seen, and only low risk, that is the previous phase we will see anatomical classification. This submassive and the small cases, this low risk, that is submassive, and in low risk and low cases we should, mild cases we will only use anticoagulation. Usually in many cases, in submissive cases, if patient condition is deteriorating, we may give the systemic thrombolysis. Let's discuss about the anticoagulation.